All right, hello everybody, all my fellow respiratory therapists, physicians, nurses, anybody who's watching this trying to figure out is it actually possible if we can ventilate four patients using the same ventilator. I don't actually know if that's possible. I'm just going to start out by saying that this is entirely theoretical, but the way I've drawn it out on paper and done a couple of calculations, it seems like it might work and avoids a lot of the complications that a lot of us are worried about. So the whole way this got started was a response to a thread on AARC Connect. Basically, somebody asking, is it possible to use one ventilator for multiple patients? I'm going to put a link to that in the description so that everybody knows what I'm talking about. And coincidentally, one of my friends that works at a local hospital here also was mulling this idea over with a couple people who worked there and had passed it on to me and was kind of saying, hey, what do you think of this? How could this work? So my brain's been chewing on it for a little while, and this is what I've come up with. So just a couple of things to go over before we get started. Lots of good input. A lot of people have already addressed some of the key issues, so I'm just going to roll those details into this video all in one. Things like humidification, what to do as far as like what mode, what to do as far as stopping contamination, all those things. I'm going to try to address every single thing that people have concerns about. I think it's worth saying also that I don't have any affiliations with any particular equipment manufacturer or anything. If you hear me use a brand name of equipment or anything, it's just because that's a particular piece of equipment that I've used and I'm at least somewhat familiar with. So it's not like I'm favoring any of the devices that you might hear me mention. I'll try to keep it as generic as possible. So a couple people who've already kind of contributed to the conversation. We had a Draeger rep, by the name of Nicholas Dawson that was in the conversation that had some very valuable input. Keith Lamb also posted a bunch of good information in the form of PDFs and I think a couple of links. And then Troy Whitaker also posted a video of one of his pulmonary critical care fellows kind of dabbling around with some equipment and seeing what they could put together. So I'm going to maybe pull some information from some of these other videos that are out there. I don't know, I haven't watched all of them. Information from some of the posts I've seen, and then of course throw in there what I think might work. So let's get into this. Another thing I did want to just mention real quick, these are some trying times, as everybody knows, and I really think I genuinely believe that all of us healthcare workers, everybody, but healthcare workers in particular, we have a drive to try to help as many people as much as we can, and everyone I think is trying to do that. They're trying to do their best. They're throwing out any idea they have, whether it's crazy or is like a total Hail Mary or whatever it is. People are just trying to come up with ideas for what do we do if things get as bad as everybody thinks they can get. So just keeping that in mind, I would just encourage everybody to try to keep your responses to people's suggestions positive. I know that there are some other videos, I'm not going to single out which ones in particular, but there were some other videos that had multi-patient ventilator setups, and some of the comments that people were putting were just really derogatory and not necessarily, and basically they focused on pointing out the fact that other people might not be as knowledgeable as RTs when it comes to how ventilators work. And you know what, that's totally fine, because everyone in the hospital knows something that we don't. Every person in the hospital you run into, everybody knows something you don't. Everybody has their specialty. Everybody has their particular area of patient care that they're really, really good at. So I wouldn't try to like fault people for trying to help, or maybe thinking that, oh, you could hook a ventilator up in a certain way and it would work for multiple patients. I think the thing is to just know that everybody's trying to do their best. They're trying to help, and we should do our best to not slap people down or be overly critical of somebody who points out something that maybe is a good idea but doesn't really work in practice, because it's that sort of thing that's going to cause people who might be shy or not want to speak up, but they actually do have a really good idea. If they see that's the response that people are getting, is that they're just getting slapped down and criticized for opening their mouth and making a suggestion, then that's not good for anybody. So it's going to keep people who have good ideas from speaking up. So everybody's trying to help. That's what I'm getting at. Everybody's trying to do their best. Everyone's trying to help. Let's try to keep all your criticisms positive as best you can. So as you guys can see here, this is the grand outline. I don't know exactly what ventilators everybody has. Again, this one that it's showing is for the LTV 1000 in particular. The reason I chose that vent is because it has an external exhalation valve, which is going to become important here in a second. And it was also pretty widely available, at least where I worked. We had quite a few of these things, and it's a decent vent for what it is. So what you have up top, up here, is the ventilator itself. So the vent, it's got an outlet, and you see it splitting down to 4 patients. So this drawing here, there's probably plenty of people who have come up with a drawing like this. This is pretty generic. The thing that I think is going to make this work is the particular inspiratory and expiratory assemblies on here. So I'll detail those here coming up, but let's just keep in mind that these are not to scale. I labeled what things I think should be the same length for just keeping all the resistances and compressible volumes and everything the same in all runs of different tubing. So if I drew it not the same length, I specified that these should all be the same length. Like these pieces of the tubing that connects to the exhalation valve, these should all be the same length. These ones right here should be the same length. These corrugated tubing runs right here should be the same length, and these two corrugated tubing runs should be the same length as well. Again, that's just to make sure that all of our resistances and compressible volumes are the same in all the different limbs leading to the patients, if this ever had to get used. Up here we have our connection line for the exhalation valve, or the little PEEP valve that these things use, and then the connection for the airway pressure and the inspiratory flow sensor. That should go, I think, right at the main outlet, right at the main bifurcation, where we start to split the circuit into many different circuits. Now, the way this is going to work in my mind is because this ventilator isn't expecting the patients to exhale back into it. It's expecting them to exhale out through an external valve anyway. I think that's a huge important factor, because that's going to stop patients from competing to exhale. Some of the other videos that I've seen, particularly the one that shows, I think there was one that had an 840, and then there were a couple other ones. Everybody shows all the inspiratory limbs being split, which is to be expected, but then nobody has taken into account the fact that they're all going to be exhaling from 4 tubes down into 1 tube, and there's inevitably going to be some sort of back pressure there, basically, which I'm trying to keep track in my head which one it would be. If it's the patient that exhales the fastest or the most forcefully, or has the poorest compliance, whatever it is. Inevitably, there's going to be some patient that's exhaling a little bit more forcefully than the rest of them, and I can see that all getting backed up, kind of like a Three Stooges effect, if you have everybody trying to exhale from their individual expiratory limbs into a combined 2 and then into a combined 1 exhalation limb. I don't think that's going to be as effective as it looks just running it on something like a test lung, particularly like everybody's pointed out, because all of these patients would potentially have different airway resistances, different compliances, and all kinds of other things that would make it so that, even though it might seem like, we dial 2,000 mLs in and every patient gets 500, I think we all know that's not going to be the case in practice. That would only be further complicated by having everybody exhale down the same limb back into the machine, and that's why I think this method actually has some hope for actually working if this ever actually had to be applied, because we'd really just be controlling breaths towards all these patients, and then they would be exhaling independently. So potentially we can control these patients with different levels of PEEP and a couple other things. So this drawing, I realize, very generic, not the greatest artwork in the world, but I just threw it together in Paint real quick. So I'm trying to hit all these points without having it take too long. Some topics that we're going to cover. I know everybody's worried about contamination prevention. That was a big thing when everyone saw this. At first, they're like, oh my God, how can you prevent these patients from contaminating each other? I've got a plan for that. Safety for healthcare workers, as far as if they're not exhaling back into a ventilator, then where's all the dirty bugs going when they exhale? I've got a plan for that. What about with the variable compliances and resistances? I got a plan for that. Inspiratory efforts. I think we all agree that these patients are going to need to be paralyzed. If this was going to happen, they would have to be heavily sedated and paralyzed, because any patient that has any inspiratory effort is basically going to steal air from all the other patients. The one who has the biggest effort is the one that's going to get most of the air. So these patients would have to be pharmacologically paralyzed for this to work. Humidification. I was reading a couple of things that said you basically want to use HMEs. You don't want to use a heated humidifier or heated wire circuits, because that's obviously going to be more connection and complication nightmare. But I'm also fairly certain that even the best of the best heated humidifiers couldn't keep up with humidifying this much gas. I don't know if that's the case, but it just seems like an extra complication, and HMEs in this case should do fine. I know a lot of people are probably screaming, HMEs are only good for short term, and they're only good if your patient doesn't have really high inspiratory flows and doesn't have secretion problems and all these other things. And I hear you. The way that I would plan on ventilating really sick ARDS COVID-19 patients with a vent setup like this, it would be done with long IDE ratios, so inverse 1.5 or 2 to 1, somewhere in there. So by default, the inspiratory flows would be very, very low, and the HMEs probably have some sort of hope of working. So we got that covered. When it comes to disconnecting and codes, whether we're disconnecting accidentally, disconnecting to swap filters, or change out any vent circuit component, whatever it is, or if it's for a code, this vent could still keep working. All we would need to do is clamp off the inspiratory limb that's leading to the patient in question. So if it was this patient that was coding or needed some piece of equipment changed or whatever it was, we could theoretically just clamp it. Well, I didn't want to zoom in. We could clamp right here, and that way the rest of these patients would still be getting their breaths delivered from this machine. What's going to happen? Isn't that going to force more volume into all three of these patients? No, it's not, because we would be using pressure control. So every patient would still be seeing, in theory, the same delta P's, the same driving pressure with every breath, assuming that they all had the same PEEP levels, the same PEEP levels set. So even though we clamp right here, because we wouldn't be volume controlling, that would be an issue if we were. If we clamp someone right here, clamp a circuit right here, the way I see it, all these other patients should still get their same pressure controlled breaths, so it wouldn't really matter if we clamped this one right here. So yeah, we could potentially disconnect or code patients while leaving the rest of them untouched. What would we do for accurate, and notice I put that in quotes, accurate airway pressure measurements? We would have to have little adapters that were proximal to each patient, connected to a manometer, that will give us the closest we're going to get to an actual airway pressure reading for that patient. What would we do for variable PEEP settings? I think I covered that in these expiratory assemblies, and I'm going to go over here on my next little image. The expiratory assembly features a expiratory valve that has adjustable PEEP, which I've used on an LTV hundreds of times. So variable PEEP settings are totally possible. Variable delta P, that's still an issue. What would we do if your patients needed to get different delta P's? There was a video that showed adding a little like a flow restrictor on the inspiratory side that would cut down on the amount of pressure a patient would get. That is a possibility. I just didn't include it in this particular video. My idea was cohorting patients by the amount of delta P they need. But again, that's still something that would need to be discussed, and I don't know if that's necessarily the best option, but cross that bridge when we get there. The whole point of this video is that I think that this just might work if we set it up the right way. What kind of tidal volumes are going to be possible with a setup like this? I'll go over that. And then as far as ventilation scheme, what to do about ABGs. I don't think I need to go too much into vent management of ARDS patients because there's already a ton of research out there as far as what settings and PEEPs and FiO2s and everything to use. I'll just keep it really basic when we get to that point. But it's basically, it's got to be pressure control, probably going to be really high FiO2s, the longest inspiratory times you can get away with, the lowest rates you can get away with, and inversing their IDE ratio so we get lots of good distribution of ventilation, that sort of thing. What else do I want to point out on here? I think I got all these main connections, everything being the same length. All right, so generic drawing. This is just, the basic roadmap, how it would get set up. The real fun and how this would actually work comes down to the inspiratory and the expiratory assemblies. So let's go over that here in a sec. Okay, so this is the detailed view of the inspiratory and the expiratory assemblies from the previous drawing. So we have basically the patient would be connected down here. So I didn't actually show the patient connection, there's no need to. Basically your patient would be down here. They would have their ET tube or their trach. We, of course, would have our closed suction attached to that so we could still suction and manage the airway. And then connected directly behind that would be our HME of choice, whatever we have on hand. And then, of course, the patient Y adapter. So what you're seeing here, everything on the left side, everything is still kept the same color coordinating. This is just the whole, what I'll call inspiratory assembly as a whole. This is the expiratory assembly as a whole. So let me go through what we have here. Everyone understands the basic patient connection, ET tube, closed suction, HME, Y connector. I'm just going to assume we all have that baseline knowledge. This also not to scale. Let's focus on what happens from the gas when it happens to the gas when it comes from the vent. So flowing in, this is the big thing right here that's going to help prevent our contamination. The check valve, along with the filter. This check valve is going to do a couple things for us. It's going to prevent gas from backflowing into the circuit, which is going to mean if our patients cough, which they inevitably will, or they have just any sort of pressure that the patient pushes back with into the circuit, that patient isn't going to push their pressure into all the other inspiratory limbs that are connected to them and mess with the other patient's ventilation. I think that's something a lot of people saw as being a huge issue, and that could be eliminated by throwing a one-way valve in right here. If I had to reach for one of those just off the top of my head, the thing that jumps into my mind is the little one-way valve piece that comes in like Therapep kits or something, or like in a RespirGuard nebulizer. There's the little one-way valves. So it would have to be, a heavy-duty one-way valve with the appropriate connections to connect to your vent circuit, so it would be able to fit to the 22 millimeter connection somehow. But those things do exist. So it doesn't have to be those particular brand names. I'm just saying these little flapper one-way valve assemblies exist. I don't know how much they cost, but that's one easy way of stopping patients from pushing air back down the inspiratory side into other patients. And if we throw a bacterial viral filter on this side of that one-way valve in particular, then that's going to stop them from obviously moving bacteria and viruses and that sort of things up the circuit. So why do we want it in this particular order? If anybody's familiar with these little flapper valves that I'm talking about, this is just the one I came up with off the top of my head. Those things don't like to get wet, and they'll get sticky if they're wet, and they won't function like they should. So in an effort to keep it dry and keep that valve itself non-contaminated, we should have it go valve, then bacterial viral filter. After the filter, so our patients we already squared away contamination and stopping patients from pushing air down their inspiratory limb into other patients. We did that with the valve and the filter. This right here, I saw the topic of, oh, what should we do if we need to give these patients bronchodilators? You could still potentially give them bronchodilators because they would be getting their metered one directional flow from the vent, and you could dispense your aerosol med into whatever adapter you want right here. So adapter for an MDI if that's the way your hospital does things, or a mesh nebulizer, or whatever it is. I think we should probably discourage traditional gas-driven nebulizers in this setup. They don't really work very well anyway with ventilators compared to like a mesh nebulizer, for example. But I figured I'd throw that in there because people might wonder, what if we wanted to set this up and give bronchodilators? I think that's how you do it. You'd want to give a little bit of space, sort of like holding chamber type space right here leading to the Y connector. But you would definitely want it after the filter, obviously. And then how would we get our semi-accurate airway pressure measurement? I was thinking we could do this with just, we called it an O2 bleed-in adapter. Like, we'd use them for nocturnal CPAP setups and stuff. I don't officially know what that little adapter is called, but it's got the little 22 ml connectors. It will plumb right into a vent circuit, and it's got an outlet that you could potentially connect a manometer to. So any manometer that has the pressure range that you want to monitor. So probably want to make sure our pips aren't going much above the 30s, 40s. So whatever your particular institution says, or whatever your physicians are comfortable allowing, we could actually figure out how much pressure is reaching the patient at their connection by adapting a manometer right here. It's the closest to the patient, it's the closest to where it would be pushed into the lungs. So that would be our most accurate, quote unquote, airway pressure measurement. This would obviously be very different than what we saw coming from the ventilator itself, where the vent's airway pressure measurement is. There would probably be a little bit of a discrepancy just because of all the runs of tubing and everything else. So when it came down to what pressures are my patients actually getting, we would want to look at this right here. Now switching over to the expiratory side, where would all this dirty, potentially viral droplet mucus-filled gas go? It would come out of the patient, go down a little run of corrugated tubing, as it usually does, and then that corrugated tubing would have another bacterial viral filter connected to it. This would be to keep the staff safe, obviously, and make sure that they aren't spraying stuff out of their vent circuit. It would also stop goobers and a decent amount of moisture and things from getting to this portion and this portion, which I'm going to detail here in a second. So this middle thing, this would be, it would still be optional, but I think we still need to have this piece in here for this to be somewhat reliable and somewhat safe. So I was thinking if we threw a flow cap in right here. I don't know how many people are familiar with flow caps, but they're basically easy caps that have like a little, they have a little vein. They have like a little pinwheel type thing in them. And they're used for resuscitation primarily, so that when you're bagging somebody, you can see when they're done exhaling because the little vein stops spinning. You could just plumb that in line here, and that would be your little expiratory flow indicator, so you could at least figure out if your patients were air trapping or not. If you still saw the little wheel spinning really fast when the next breath hit, you'd know that the patient wasn't done exhaling, and we'd have to try to adjust things accordingly. Or potentially you could put in an adapter for, I don't know, whatever you have on hand that's going to measure, whatever's going to measure volume, whatever PFT devices you have, like maybe figure out a right spirometer. I don't know if it's possible to figure out, I don't think a Venticomp bag would work, or if anybody even has Venticomp bags anymore, but just something, whatever we have that would give us an idea. Is there expiratory flow? So just qualifiers, whether or not there's expiratory flow, like the flow cap, or if we have some sort of adapter and measurement device we can put in there, some sort of pneumotac or some sort of spirometer that we could adapt in there to get a handle on flow or volume coming out of the expiratory limb. And then it would flow into our exhalation valve that has adjustable PEEP. So this little gray line here, that's just the connection that goes back to the ventilator that drives the exhalation valve. We would dial that up to whatever PEEP level we wanted, because our patients are obviously going to need some increased levels of PEEP to keep them from de-recruiting and keep their oxygenation up. So we would be able to potentially adjust the PEEP levels on a patient-to-patient basis, and then keep the whatever pressure, whatever driving pressures coming from the machine would stay the same, and you could manipulate your manipulate your PEEP level with the valve right here. So potentially we would have nice, clean, uncontaminated air coming this way from the ventilator, check valve, filter. If we're giving aerosol meds, whatever adapter it is to do that, a O2 bleed-in adapter, which is only being used to adapt a manometer so we can get a hold of airway pressure, HME closed suction to the patient, they exhale, down a little bit of corrugated tubing through a bacterial viral filter, keeping all of this nice and dry and mucus free and everything else. If we do have a flow cap or some sort of flow or volume measuring, that would be awesome. If we don't have this, I suppose that the setup would work if you just put the PEEP valve straight up to the filter, but we really should try to get some sort of handle on whether or not there's expiratory flow, and if at all possible, what that expiratory flow measurement is, or if we can get any kind of accurate expiratory volumes. So not 100% necessary, but I think we can all agree that would be really nice information to have, so that would go right there. So I think this is, if you have all these little parts, which I think most hospitals should have, you should have most of these things available to you. I think you can make, I think you could make this work with this ventilator in particular, or any other ventilator that does pressure control and uses an external PEEP valve or an external exhalation valve. I think that's the key to making these work. Now, when it comes to the idea of actually delivering acceptable volumes to these patients, the question will inevitably come up, can that vent even keep up with feeding 4 patients enough volume or enough minute ventilation, because that vent was really only designed for 1 patient and all these other things. So is it even possible to push enough air to 4 different patients from 1 ventilator? It's kind of like the same idea as asking, you know, can I plug 4 refrigerators into the same electrical outlet? Is that going to blow the breaker? Is there enough juice to feed all those refrigerators? Is that going to work? Well, that might have been a bad analogy, but in our case with these patients, with this ventilator, I think it would work. Then the reason I say that isn't just a whim, it's because I did a little bit of math, so don't rack your brain. I went through and did all these calculations for you so that we had a little bit of data to look at. The specified inspiratory flow that comes from an LTV, I went and looked it up. It says 100 liters per minute for inspiratory times between 0.3 seconds and 9.9 seconds, I believe. If we split that 100 liters per minute up across 4 patients equally, that means each one of those patients will potentially get 25 liters per minute. 25 liters per minute per patient of inspiratory flow. So what does that work out to as far as mLs per second? 25 liters per minute, that's the same as 25,000 mLs per minute, which is the same as approximately 416 mLs per second per patient of potential volume delivery. So that might not seem acceptable. Oh, well, I know normally we have inspiratory times around a second for most of our adults, and 416 isn't going to be enough except for my tiniest patients, so that's definitely not going to work. Well, here's my modifiers I'm going to throw on there. This 100 liters per minute, if we look at the asterisk, I'm assuming that this is constant flow, because right below that in the specifications it said its pressure control flow was 160 liters per minute. But we know that pressure control doesn't have constant flow, so it would be very difficult to do these calculations. So these calculations are based on the idea that the LTV can comfortably deliver a constant flow of 100 liters per minute during the inspiratory cycle. I hope everybody understood that, but it gets kind of confusing. So maybe it's able to put up with 100, or it's able to put out 160 liters per minute when it's in pressure control, but that would just be a peak flow, and then it would start decelerating. So to make the math easy and just figure out if this vent can come even close to giving us the volumes we want on a per patient basis, I used the 100 liters per minute of flow. So if it's 160, this would look even better. If it's actually 100, then this is the numbers we get. So moving on. 100 liters per minute, 416 mLs per second per patient. What would that look like if we set them up? Obviously, it would be on pressure control. They're probably going to have some high rates. I'm sure their CO2s are going to be up because their compliance is terrible, and I'm sure their oxygenation is going to be terrible. So FiO2 and PEEP would need to be determined for the patient. This is just purely looking at, can the vent deliver volumes that are appropriate for patients that we might see that are getting sick. So how do we know if it's the right size patients, right volumes, everything else? I just went ahead and I looked up what's the average US adult height. So it turns out, according to Google, average males in the US are 5'9", average females are 5'4". If we do a quick ideal body weight calculation, the calculation I used for this, because I know there's a couple different ones, the one I used is starting with 106 pounds, and then you add 6 pounds for every inch over 5 feet for males, and then of course just make your conversion of your final number into kilos. For females, it's 105 pounds plus 5 pounds for every inch over 5 feet. I might have misworded that when I said it for males, but I'll put that in the description too, just so everybody knows how I got to these numbers. It's just a textbook calculation of figuring out ideal body weight based on height. So if we go with average US adult height, that means we get average ideal body weights for males and females in the US of 72.72 and 56.81 kilos respectively. If we apply our lung protective strategies as far as ventilation goes, going for somewhere between 4 and 6 mLs per kilo. Again, for average adults, that would mean for males, at the very most, 6 mLs per kilo, we would only need to be getting them 436 mLs per breath. And again, that's average males in the US. For females, it's even less, 340 mLs. So all of a sudden, it seems kind of feasible that we might be able to deliver the tidal volumes that we would expect we would need to deliver to these really sick, stiff lung ARDS patients. What if the patients were a little bit bigger? So I didn't make the calculations for every single size patient, but I just wanted to throw some rough ranges out there. What if the patient was a little bit bigger? What if they were 6 feet tall? Ideal body weight for a male that's 6 feet, according to my calculations, is 80.9 kilos. For a female, it would be right on 75 kilos. So even with patients that are on the larger side, if we were shooting for 6 mLs per kilo, which for ARDS is really about the most we should be shooting for, even for males, we really only need that vent to be able to push 485 mLs of tidal volume. And yes, I realize that they would be in pressure control, so we wouldn't actually be setting a tidal volume. Again, this is just trying to figure out, could this vent push that much volume in the amount of time that we're giving it? The amount of time being our inspiratory time, which would be a function of our cycle time, and of course our rate that we set on the ventilator. So looking at our numbers over here, I know this is getting a little confusing. I'm trying to make it as straightforward as I can. So it would be pressure control, it would be AC, there'd be no spontaneous efforts because we already said that would wreak havoc on the system, so our patients are already paralyzed, so the machine is doing all the breathing. So if we set the rates that we're typically going to see with patients like this, somewhere in the 20s to low 30s, we shouldn't really be going higher than that because these are adults at the end of the day. We've got our cycle times decreasing ever so slightly as the rate increases. We're going to keep our I to E ratio the same for this top set of data, and then the I to E ratio switches for this bottom set of data right here. So if we give an inverse I to E ratio of 1.5 to 1, well, it is inverse, so it's going to help improve our oxygenation and our distribution of ventilation and everything else. But that's not ideal. That's not perfect for these patients. I want to argue that if they get really, really bad, they have the worst of the worst lung compliance and oxygenation, and their CO2 is through the roof. If they're going to be paralyzed anyway, we should be going with longer, more inversed IDE ratios. So I just wanted to provide a couple different data points so we can see what we're working with. Look at it here. We can see cycle time, IDE ratio, I time, and the corresponding theoretical tidal volume that would be delivered at the constant flow. Again, we know it's not going to be constant flow when we're in pressure control mode. I'm just trying to figure out if this vent could keep up with 4 patients all connected to it that needed certain size breaths. So what this is really telling us is if all 4 of these patients, if we had these particular settings, so a rate of 24 and whatever driving pressure we had, and the patients have their PEEPs set, if we had them at an IDE ratio of 1.5 to 1, which would mean an I time of 1.5 seconds, well, we would squeeze potentially 624 mLs. We would squeeze 624 mLs into those lungs theoretically. That's if they were totally happy lungs that were happy to accept volume, which we know ARDS lungs are not. All that this is showing you is if the vent flowed at 100 liters per minute and was connected to 4 different patients, with these settings, what volume could you reasonably expect to be delivered to each patient? So that's what this double asterisk tidal volume down here is. It's the theoretical volume delivery at constant flow with the lung mechanics actually allowing that. So I know there's lots of things that factor into whether or not those lungs will actually allow that much gas to go in there. But at least this gives us some hope that, if we had to ventilate these patients, these settings, this is really getting high up on our rate and pretty inversed on our IDE ratio. This is the I time that you would have, and for this amount of constant flow, you would potentially be able to push 553 mLs to each patient connection. That's all that means. Whether or not the patient would get that, I know that's going to depend on a lot of things, but it's actually looking pretty hopeful because even if, we had bigger patients, so let's say they were on, 6 feet or maybe even a little bit bigger, your big, 6 foot or more males, and they're getting 6 mLs per kilo, they're going to need 485 if they were taller, maybe, somewhere around a little over 500. Well, we're still comfortably able to theoretically flow over 500 mLs to each patient, even if we have high respiratory rates and we have long inspiratory times. So that's all I was trying to demonstrate there, that it's feasible. It's feasible according to all these numbers that each patient connected to the single ventilator would be able to get all the volume that they need if their lungs would only accept all that volume. So let me see if I got us squared away with all our topics that I wanted to cover. So contamination prevention, we did that. That's the little check valve on the inspiratory limb and the bacterial viral filter on the inspiratory limb. Healthcare worker safety, we've got the bacterial viral filter on the expiratory side, as well as us going to clamp the inspiratory limb of any patient who has to be disconnected for whatever reason. The variable airway resistance and C-stat, we're sort of addressing that issue because we're going to use pressure control. I think we can agree that if we used volume control on 4 patients connected to the same ventilator, if they had anything but the exact same resistance and compliance and they were all about the same size, that would have disastrous results. So the way we can get around that, all the patients having variable resistances and compliances, is instead of targeting volume on the breath delivery, we just target pressure. So we use some sort of pressure targeting, pressure controlling scheme so that the vent isn't concerned about delivering an exact amount of mLs. It's only concerned with pressurizing the airways to a certain preset pressure, and then whatever volume flows into the lungs is the tidal volume we get. So that's how we deal with the variation in lung mechanics. Patient inspiratory efforts, like we said, we're just going to paralyze these patients most likely, because if any of them start to breathe connected to this, it it would just, they would basically hog all the flow, and all the other patients would miss out on their breaths. Humidification, we're going to say HME for now. I haven't had a whole lot of opportunity to test that or do anything, but that was just one of the little tidbits I read from something that someone had posted earlier, was that you don't want to try to rig this up with a heated humidifier. You want to use whatever HMEs you have available, preferably the best HMEs you can get, but in a situation like this, it's whatever HMEs you have. Disconnecting encodes. Again, clamping the inspiratory limb of any patient who needed to be disconnected for whatever reason would still ensure the function of pressure-controlled breaths being delivered to the rest of the patients, and we wouldn't be spraying nastiness all over the room. Accurate airway pressure measurements. The vent is going to have its airway pressure measurement, which is done at the connection that is proximal to the vent. The connection that is proximal to the patient with that little O2 adapter with a manometer, that is where we would get our semi-accurate airway pressure measurement. Variable PEEP settings we said we can do, because each one of these patients can have an individual PEEP set on that external exhalation valve. With variable delta Ps, that would kind of be the hard thing. That's what I still haven't figured out. I haven't put together too many schemes here. It seems like if we really had to do this, we could have, one station set up as, like the higher driving pressure station. So patients who needed higher driving pressures were connected to this machine. Patients who needed lower driving pressures were connected to this similar setup, but one that had a different driving pressure. You could also manipulate the driving pressure by changing the PEEP, but we know that we probably wouldn't want to be adjusting our PEEP too much, because that's going to have a huge impact on our tidal volume that's delivered. How much tidal volume can get delivered, this is what we were talking about down here. So again, just rough estimates of what this ventilator is theoretically capable of delivering on a 4-patient setup on a per patient basis, with just some pretty common settings that we might see. And then as far as ventilation scheme, it would have to be pressure control, it would have to be AC, or it would really just, they wouldn't be assisting the machine at all, but we would want it to be pressure control AC set in the machine, patient paralyzed and heavily sedated. And then the longer inspiratory times we could get away with, the better, because with these really stiff lung patients, we're going to want to distribute the ventilation as best we can. We're going to want to re-recruit as many alveoli as we can. And the faster we cram that air into these sick, diseased lungs, the more that air is just going to rush to the least diseased areas and over-distend and potentially cause all kinds of problems. So the slower we can trickle that gas in, the better chance it has of working its way down those super distal airways into the most diseased areas of the lungs. And as long as we set our PEEP appropriately and we're not excessively disconnecting and excessively suctioning, those kinds of things, we should be able to maintain some recruitment and get decent ventilation. I'm hoping that's the idea behind inverse ratio. So we can at least hopefully oxygenate these patients, get some CO2 out of them. As far as the ABGs are concerned, you would just need to be very diligent about operating within the parameters of permissive hypercapnia and permissive hypoxemia. So if you guys have a particular policy, or however you do it at your particular institution, what you guys think is acceptable for permissive hypercapnia and hypoxemia, we would just want to be very good about operating within those limits, but maybe pushing right up to those limits, because we wouldn't be able to control every single aspect of every single patient like this. But if we kept an eye on them, and as long as everybody was still in the permissive range, they would still potentially survive to the point where we could get them their own ventilator eventually. I think that's really what we're going for. And at the end of the day, if we can't actually measure tidal volumes or anything like that, we can't measure our minute ventilation, the blood gas is what's going to tell you. So if their CO2 is still really, really high, we're going to need to figure out a way to get more volume out of them. So whether that means increasing your rates, increasing your driving pressures, whatever it is, whatever tips and tricks you have up your sleeve, um, that's what we're gonna have to do. So hopefully I covered most of the issues that people see as being just giant barriers to this ever working. Again, I don't think that this is a great thing to ever have to do. I would never ever want to have to do this. But ever since the topic came up, it really got me thinking. This might actually be possible. Again, I haven't tested any of this. I would love to have all this equipment available to me and be able to run a couple of different experiments and things, but the unfortunate reality is I just don't. I just wanted to do my best to contribute to the conversation, and basically, if anybody has anything they want to add to this, you spotted an error I made, something I didn't account for. I'm sure there are things I didn't account for in here. I just tried to cover as many of them as I could and make this particular setup make it seem less impossible than most people think it is. Because I think people's initial reaction to this is, oh my God, this is ridiculous, this is impossible, this will never work. And most of the setups I've seen that people have been passing around, it doesn't seem like they would actually work. This, at least on paper, seems like it might work. Again, maybe I just like it because it's my idea that I came up with, but it seems like it just might be a somewhat acceptable way of ventilating multiple patients with a single ventilator. So I think that just about does it. Thank you for sticking with me this long, you guys. Sorry, I tend to ramble a little bit, but I try to keep it to a minimum. I was just trying to explain the method to my madness, my thought process behind all the different elements here, trying to explain how I got the certain numbers I got, and everything else. So let's please keep this conversation going. I don't expect that this is like the final say on multiple patient, one ventilator topics. This is just my contribution. This is what I think would work. Please feel free to add more onto this. Throw on some modifiers that you guys think would be needed. If I totally botched something, or there's something on here that you realized isn't exactly accurate, please let me know so I can do my best to change it. Until next time, everybody stay safe out there. Do your best. Let's try to figure it out and see if it's feasible. All of us hoping that we would never actually have to do this. So take care. We'll see you guys next time.